Welcome, everybody. My name is Becky Slangen. I'm Associate Dean for Academic Administration here at the Geisinger College of Health Sciences. It's my pleasure to introduce our speaker this evening, Dr. Ghila Kaberi Oderad. She completed her medical degree at the Iran University of Medical Sciences before moving to New York, where she finished her residency in internal medicine at Flushing Hospital in Queens. She then pursued specialized training with the Fellowship in Nutrition and Nutrition Support at Columbia University. She is board certified in internal medicine, a diplomate of the American Board of Nutrition Support and American Board of Obesity Medicine. In 2014, she joined Geisinger's Nutrition and Weight Management team, where she played a key role in establishing and expanding clinics across northeastern Pennsylvania. Today, she continues her work as a physician in nutrition and weight management, caring for patients with a wide range of nutrition-related and weight-related disorders. She has a particular interest in nutritional deficiencies in individuals with obesity, as well as in patients who have undergone bariatric surgery or experienced significant weight loss. Please join me in welcoming Dr. Ghila Kaberi Oderad.
I hope you can hear me. Okay. Well, thank you very much. I am so excited to be here, and it's an honor. Let me just get to this. So these are the objectives for my talk, and hopefully by the end of the hour, I can check mark those and talk about all the objectives appropriately. So I'm going to start by a very simple, very short definition of the obesity, which is pretty much excess fat mass accumulation and disease of the fat mass, the inflammation, the extra fat that can cause a lot of complications, pretty much can reach all the organs, and disorder or failure of those organs due to the excess fat can be devastating as well. So certainly obesity is a very complex disease, very important one. But also we'll see that the prevalence of obesity is high and is increasing. So we are at the pandemic level in terms of the prevalence. It is not just it's our country or, it is a global issue. But also if you look at those graphs, the upper graph, you see that for adult patients, not only the prevalence is high, but also over the past 50 years, the prevalence continues to go up. And the concerning is that we are seeing more severe obesity. The bottom graph is the childhood obesity, which it is concerning as well. The prevalence will see that is still rising. So we know a lot more about obesity, the physiology, the pathophysiology. We have more effective medications. We have bariatric surgery, which is very effective in terms of treatment of the obesity. But this pandemic or the prevalence kind of continues to rise. So there are a lot of reasons for that. We have perhaps close to 100 contributing factors that this pandemic is continuing and is affecting the obesity and the pandemic. But as a clinician, when I was thinking about it, I'm thinking one important factor can be the fact that obesity also is very much misunderstood. So, for example, if you're talking about the causes of obesity, we still have about 70% of people that they think obesity, the most significant cause of obesity is the personal bad habits. They feel like they're eating unhealthy foods or decreasing, less exercise is the most important cause of the obesity. So these type of perceptions can have negative consequences in the long term. So what happens, we are shifting the blame from the physiology or pathophysiology of the disease to the patient with the disease. So the patients may actually feel that this is their fault as well. So sort of becomes like a perpetual increase in those maladaptive behaviors. It has personal, social, physical consequences for the patient, but also makes the patients not seeking help. So we have, as a matter of fact, we have a lot of patients that they have indication for medications or surgeries, but we really treat very little number of those patients. So they're not seeking help. So some of the beliefs like eat less, exercise more, or this is willpower, or this is the personal choice. So when we're talking about that, I thought maybe it's a good idea to have a look at that and see if there is any evidence for it that we're saying it, or maybe some ideas against it. So in order to look at the disorder or disease, might be a good idea to step back and look at the physiology. So, and I try to make it very simple. Hopefully, you stay with me. And, it is a very complicated system, but as I said, I simplified it very much. So one fact that energy, nutrient, is essential for survival. So throughout the evolution, genetic evolution, human evolution, the evolution did not leave the control of such an important and essential factor for survival to chance. So the evolution has developed a very complex neuroendocrine system to control energy. So we have energy homeostasis in our body, and to control the energy and the weight. So we have a set point that the body controls that very tightly. And the center of the control or thermostat of the energy homeostasis is part of the brain, hypothalamus. So the goal is to control this, the energy balance, to make sure that energy is not the body is not deficient in energy, but also it is not used, it's not wasted. So it also developed a system to store that extra energy. So throughout the evolution, early years, the human beings, when there was episodes or periods of starvation, famine, that the food was not available. So the energy use was decreased, and body kind of adapted itself until the food was available. And when the food was plenty, the extra calories were stored in the fat mass as a storage of the energy. But the hypothalamus is not doing it just kind of on its own. It gets a lot of communication and input from the periphery or the other organs in the periphery of the body, including the gut that has a lot of hormones, but also in terms of the neurologically and hormonally can send information about the availability of food. So each time we are eating or the lack of food, we get signals, including some of the hormones like GLP-1s, which are satiety hormones, or ghrelin from the stomach, which is a hunger hormone, to let the hypothalamus know where we are in terms of the food availability. And then in terms of the fat mass, even though it's a storage system or storage organ, they still, they are very active and they produce hormones to relay the information about the storage status of the energy as well. So one of the famous hormones is the leptin, and that is relaying the information to the hypothalamus. We also have a few other areas in the brain that, it's a very complex circuitry that neurological, the neurons together, they can pretty much, we call it the reward system, because can enforce behaviors, can also, be a source of like and dislike, the pleasure or displeasure, and sort of it makes the memory of the food. Let's say if you have food that likes it, or it is good, the pleasure of that sort of stays in the memory. And if there's a dislike of something, again, that memory later on is going to be other, information to the system as well. So, did they do anything? Okay, very good. So what happens, again, in the period of starvation? The gut hormones, the hormones from the fat cells, the reward system, those hormones are going to stimulate the hunger center. And the result of that is going to be increased food intake and decrease energy expenditure. So, and also the reward system start to enforce some of the food-seeking behavior. So it's not just I'm hungry, the food is not available, but also I get the motivation or that aggressiveness to go for food. So the result of that is going to be, again, to gain weight or bring the set point to where it was supposed to be. But for whatever reason, if we have that extra amount of calorie continuously, one of the theories that how we gain weight is that the body pushes that set point to a higher level. So continuous positive energy balance, the set point goes higher, and now the body starts to control that higher set point instead of the previous one. So a lot of things, these are the whole system is not happening by chance. So it is genetically is designed to control the set point, and it is not just, it's not a conscious change that is happening. So it's not like I say, okay, well, I ate that much of a calorie, now my storage is low, so I have to stop. So the consciousness has nothing to do with this control. It happens according to the input that is getting, and that is the result. So this is a very nice picture that I got from Johansson et al. Article, very nicely kind of explaining that. So if you think that the brain, the system, the control system is in the background of genetic, it is not alone. We are not alone. We have a lot of cues from the environment, and all these factors in environment can give information cues to the brain. And this is just a few of them, but we have a lot of contributing factor to, from the environment as well. Something from physical activity, ultra-processed food, diet, going to aging, circadian biology, drugs, very importantly. So all these things, at the end result is going to be change in eating behavior and energy intake, energy expenditure, and also where the storage of the fat is going to be, which organ, and where is going to be stored. And the final phenotype is going to be according to all of these. So that's why we are all different in terms of the weight, in terms of the BMI. So that would be the final result of all these interactions. So the question is going to be, so we know genetic has a lot to do with that. And before I kind of go through that, I have to mention any of those pathways that we discussed can be interrupted or be different according to the genetics that we have. So we do have two types of obesity, and I want to mention that because of the importance of the environment as well. But one is that one gene there's mutation, or this is one gene, monogenic obesity. This monogenic obesity usually is severe, starts from childhood. It's not common, 1 to 5% of the obesity. The type of obesity that we are talking about as a pandemic is polygenic. So we have a lot of variation of the genes that together can cause different the results in terms of the weight gain and the BMI. So we may have a few of the genes variation or several, but that is a polygenic obesity that we're talking about. I just want to kind of mention that. So the question comes in sometimes that, okay, so if it is genetic, but still kind of environment is very, significant. That is the most important things. If you look at it in terms of the BMI and what is causing how much of that BMI, 60 to 70% of the obesity or BMI is genetic. And it is significant. The obesogenic environment, on the other hand, is 30 to 40% of the BMI. In other words, if we have genetic that is predisposing the patient to the obesity, then that genetic sort of, we can say, I quote that from an article, genetics load the gun, the environment pulls the trigger. And that environment starts kind of, causes the, expression of the genetics as well. So then again, question is going to be, and I get that from my patient as we go. I mean, we can talk about some of the scenarios that we kind of, see as well. So my patient may say, okay, well, I have family that they are all having a problem with the obesity. There is no way that I can lose weight, or I am destined to have, to be the same because of the strong genetic predisposition. So there's doesn't matter what I do. But this is not true, because environment can change the expression of the genes. So if we have twins that they have the same footprint of the DNA, and they have, let's say, this twin, they have the predisposition for obesity. In two different environments, obesogenic environment or healthy environment, one of them in the obesogenic environment expresses the gene, it gains weight. The healthy environment person may not gain weight at all, or much less than the other twin. This comes to another topic of the epigenetics. So the food you're eating, the nutrients, toxins, medications, different things can actually change the expression of the gene. The gene does not change the gene sequence, but may chemically, for example, causes methylation of the gene, sort of like a lock and unlock the gene. So the healthy environment can prevent some of the expression. Obesogenic environment may unlock those expressions, and the result is going to be the full expression of the gene or blocking it. The most important that I want to mention also is the fact that it is inheritable. So it is important, again, we're talking about prevention of the pandemic. It is very important to say that changing the environment, even though it is not the main reason or the significant cause of the obesity, is very important to control the expression of those genes and prevent further obesity, hopefully. So, okay. So this way we know that obesity is a chronic disease. Genetics are the significant cause of obesity, but also genetic is not destiny. So, environment can modulate the gene expression. The other thing that we are hearing is eat less and exercise more and willpower. We talked about it. Is there any reason to believe that? So I'm going back to the set point and the control of the energy balance again. So what happens when we lose weight? When we lose weight, the body starts to do the changes that is needed to defend the set point by causing the weight regain. So the hypothalamic response changes, the hormones that we talked about, leptin goes down, GLP-1 goes down. Those are satiety-inducing hormones. The hunger hormone ghrelin goes up. We have metabolic adaptation, meaning that body starts to preserve energy. Metabolic rate goes down, energy expenditure goes down, and also behavioral changes that we talked about. The hunger and craving increases, and food-seeking behavior increases. So sometimes even, if you have a period of hunger, you feel like, you're craving for something that usually you may not even like that much, but the craving and food-seeking behavior is very strong. And you may say, okay, well, still eat less and exercise more should take care of it. And it is all dependent on willpower. And I'll bring you to a study that was done on the lifestyle modification and effect of that on weight. The Look Ahead study was a large study that was done on patients with diabetes. So they put the patients in two groups. One of them just the standard care diabetes, and the other one, the other group was patients with intensive lifestyle modification. And when we're talking about intensive lifestyle modification, they did pretty much everything intense. They had the calorie deficit, about 1,200 to 1,700. They had that, continuously. They were exercising to the guidelines, about 150 to 200 minutes a week. And also they also had behavioral modification. They worked on the trigger, recognizing the triggers and all the things that we're going to talk about a little later. But with all of those things, and the standard group, they just had the standard, some education, the standard of the diabetic care and all. So they've continued those, the study about 4 years, but then, continued to analyze the data. This is sort of 8 years on that. So what they know is that the first year, there was a significant weight loss in intensive group, and that was significant. But then the rest of the years, as you see, gradually the weight regain happened. So by the end of the 8 years, they gained a substantial amount, but they were not at the what it was before, but still they regained a good amount of that weight. So this is, again, this argument goes against willpower, eat less, and exercise more, because the intensive group therapy, they actually did all of those. So it is not that they deviated from, the calorie deficit or the exercise was not there. So they did that for 8 years, but still the weight, gain happened. So something else is going on that choice and willpower does not explain it. So, so I hope that really kind of, put a little, what you call argument against feeling that the patients, when you see a patient, it is their fault or they're not, doing what they need to do. So it is very important that we have, some explanation for that as well. So then it comes to the management of obesity as a chronic disease. And I'm going to go briefly through, the management and some of the treatments that are available. But before starting, treating the patient, always at the beginning and all throughout the time that you're managing the patient, a few things I think that we should recognize, but also let the patient know too. So, so for example, we know that obesity is a multifactorial disease, so we need to really kind of mention to the patient that also the treatment should be multimodal and multidisciplinary. So it's not just giving the medication, you're done, or there are a lot of other things. We're going to talk about that, but it is going to be multiple modality and multidisciplinary treatment. We have to modify the causes that we can modify. We talked about all the environment stuff, like the medications. Pretty much everybody these days, I guess, is some sort of over-the-counter or herbs or some medication. We have to pay attention. A lot of those medications actually in the long term they have potential for weight gain. And this is a modifiable thing. Some of the endocrine changes that might happen, like making sure that the thyroid is functioning well and all. So those modifiable causes, we have to find and treat them. So obesity is a chronic disease. Like any other chronic diseases, long-term treatment is needed. So it is no different from other chronic diseases. So anything we do needs to be long-term. And like any other chronic disease, again, we have to expect remission and exacerbation. Those weight gains after the weight loss, and then, one time patient comes in and they have, they have lost 2 pounds. The other time they come, they have gained a few pounds. We're going to have those ups and downs, and then we get to the plateau sometimes. So we have to expect that, and we have to let the patient know to expect that. So it's going to be not a point of disappointment, but to, kind of reevaluate and just kind of, recalibrate pretty much. One thing that I think perhaps should have been at the beginning is focusing on the health benefits of the weight loss, not specifically the number to come down. So it is important for the patient to really also know, okay, well, your blood pressure is better. That's great. That is one of the goals that we want to achieve. Not necessarily, oh, I just lost 2 pounds now, so this is not, kind of get disappointed. The health benefit of the weight loss is very important to be emphasized, because pretty much in terms of the treatment of chronic disease, the obesity we're talking about here, and looking at all the complications that can happen, that is perhaps the most important goal, to prevent those complications. So the health benefits needs to be emphasized. And again, like any other chronic disease, weight prevention. So sometimes, regardless of how much the patient needs to lose or how much they weigh, we may want to be also emphasizing that you didn't gain weight. That is great. So we do not want to continue to gain that weight. So the prevention of the weight gain to begin with should be one of the goals. And then what is the weight loss goal? So it is a good idea to have a discussion and have a goal, which is going to be individualized. So the goal should be different and according to the patient. I have a patient, actually today I had a patient that was telling me that he said, the only thing that I want to do is just to lose some weight that I can get around. So I'm not going to be dependent on anybody else. Or I have patients that they may need to go for some sort of surgery. They may have organ transplantation. They have a good amount of weight loss. They need to lose significantly a little faster. And also we have cases that, for example, I had a dress last year and it was very nice. Now I want to fit into that dress now for a wedding maybe in 10 days. So we see it's all sorts of goals. But what is the goal for the patient? But the most importantly, we have to make sure it's realistic. So if you put the patient on a goal that is not realistic, we set up for disappointment. And one thing that I want to mention from our standpoint also kind of to know is that even 5 to 10% weight loss, we achieve some health benefits. And that is shown in terms of improvement of the lipid profile, in terms of the blood pressure, in terms of the functional status. And it doesn't matter how much the patient needs to lose. Sometimes my patient says, okay, well, I've done everything, and this is 6 months in the program. The starting weight was 30 pounds. Now I have lost 20 pounds. What is it going to do, 20 pounds of, from all the... No, but that is the health benefit that you're getting. Your blood sugar is better controlled. That, benefit, the health benefit that you need, you can achieve it even with that amount of the weight loss. And then we're going to work on the rest. Even if you have a goal of 5 to 10% weight loss, we can have the, benefit. So then in terms of the, what is available, I was thinking about putting those on the kind of pillars, but then I'm thinking now nutrition, physical activity, behavioral modification is the foundation. So again, how important that is for changing the course of the obesity that we talked about. It is very important, even though we may not expect that much weight loss from from all this lifestyle modification. We may expect around, again, about 5 to 10%. But it is important to start that as a foundation of the weight loss and continue that. And then we have pharmacotherapy and the bariatric surgery, depending on the patient's indication. So I would start the treatment from BMI of 18.5 above. BMI 18.5 to 25 is normal. Is a normal, healthy body mass index. But again, I think about the obesity as a chronic disease. So you have to prevent. Primary prevention. First thing, make sure that, the weight gain does not happen. Again, I have patients that, I always ask them, okay, you need to lose weight and you need to do changes, but how about your family? How's your husband? Does he need to lose weight? Is he really changing things with you? And I've heard that a lot. No, he just eats and eats. He just does, all this, I don't know, fast foods and all, and still not gaining weight. But so he doesn't need to change. But I emphasize how important it is to really prevent, weight gain, but also, again, metabolic disorders. But it needs to start from the healthy weight. So especially with children we're talking about. So the prevention, starting from the healthy BMI, nutrition, physical activity, behavioral modification, and all through. So we have to continue that. Even if we had pharmacotherapy, bariatric surgery, we need to continue these 3 treatments. And then when we get to body mass index of 27, which is overweight, if there is a complication of the obesity, importantly, sleep apnea, diabetes, high blood pressure, and high cholesterol, or the body mass index above 30, which is a class 1 obesity, we can add pharmacotherapy. BMI above 35 with complications, or BMI of 40 by itself is, again, the indication for bariatric surgery. So now we want to start the lifestyle modification with nutrition, physical activity, and behavioral modification. I just want to put a few points there. I'm not going to go into details, a lot to talk about each one of them. But one thing about the nutrition is that we need calorie restriction, obviously, for the weight loss, but also macronutrients or the meal composition is going to be very important as well. So we need to really pay attention to both of them. So the calorie deficit can be achieved by low-calorie diet, portion control, meal replacement, intermittent fasting. The macronutrients, we have different type of diets. low carb, low fat, high protein, all these sorts of diets are available. But in terms of short-term comparison of all those, they are all causing weight loss as long as the calorie deficit is there. And they also improve those risk factors like lipid profile and blood pressure and all. In the long term, I do not think that we have a long-term comparison of the diets. But one type of diet that is going to be, it is really studied in epidemiological studies for a long period of time, but also has very good cardiovascular health benefit, and it is considered anti-inflammatory diet, is Mediterranean diet. So I just want to mention that. But the bottom line is that for nutrition, adherence is the most important thing. So it doesn't matter, what diet you put the patient on. If they're not going to be adherent to it, if they don't, they cannot sustain it, that might not be a good idea for the patient. So we need to make sure of the adherence. Physical activity, 150 to 200 minutes per week is the guideline. But again, I'm talking about, my day and the patients that I'm seeing. It is very important. I mean, if the patient is a healthy BMI, they can do that. That is great. We're going to encourage that. But a few things that I want to mention here. My patient may say, okay, I cannot do the exercise. First of all, I have, so much knee pain or joint pain. I can't even move. So I certainly cannot do the exercise. I have patient that is telling me, I have gained weight because I just cannot exercise. Or I have patients, so I don't do it at all because I'm not able to do really anything. It's very difficult for me. Or I have patients that actually they're doing everything appropriately, doing all the 200 minutes or even more. They have personal trainers, and they are very disappointed because they're not losing weight. They lost a few pounds, and now they're not losing more. So they get disappointment that way. So a few things about the exercise is, first of all, again, pay attention to health benefit of the exercise. So you have to continue that exercise as much as you can, just to kind of for the purpose of the health benefit, also cardiovascular health benefit. It also may have there is some evidence that might actually change the gut hormone levels as well. So, but we need to continue the exercise for the health benefit, but also we have to emphasize that it is not all or none. It is not like if you cannot go to, to have that, to achieve the guidelines, to forget about it. Anything they can do is they should start, and they have to start moving. If they can do chair exercises, they can do some weightlifting, very light weightlifting, elastic band exercises, anything that they can do, we have to encourage them to start. And the last thing that I want to mention is that to my patients that they are disappointed and they want to stop exercising because they're not losing more weight, is that actually we do not expect that much weight loss just with the exercise. Yes, we do have some weight loss with the cardios and all, but the effect of exercise that we are really kind of focusing on so much is to maintain the weight loss. So we talked about, the weight regain when the body starts to kind of decrease the metabolic rate and kind of conserves that energy. The muscles are the powerhouse of the body. So when we have more muscle, it uses the energy and also, keeps up. It's correlated with the body, the base metabolism. So this way we can minimize the drop in those, metabolic changes. So it helps us to maintain that weight loss going forward. Behavioral modification, it is to support dietary intervention that we're doing. And it's for any type of diet that would be helpful to correct the maladaptive eating behaviors. It is shown in some of the studies, like the Leucadia study that we talked about. They had behavioral modification on, but also some of the medications, the studies on the medications, they added behavioral modification, and it caused more weight loss. It helped with the weight maintenance and also the weight loss as well. So a very important component. It can be like self-monitoring, finding the triggers for the weight gain or overeating. can also help the patients to find a way to solve the problem. Like, if they're not able to keep up with the diet that was prescribed to them because let's say their work place is not allowing, or it's not really easy to have that type of diet. So, if they can find an alternative, if they can find a solution to that, they work with the patient, and really, if there's a relapse, how to get back on track. So the behavioral modification actually is very, very important. It can be individual therapy, it can be group therapy, but it is a very important part of the weight management. Then we get to the body mass index, that is the pharmacotherapy is going to be indicated. But pharmacotherapy overall, about 5 to 10% weight loss is expected to happen. So what we have available, I put them in 3 categories: centrally acting medications. We have bupropion and naltrexone. Bupropion is originally is a antidepressant. Naltrexone is the opioid receptor blocker. They both naltrexone and bupropion, they synergize each other's effect, and it can reduce the appetite by controlling the hypothalamus or affecting the hypothalamus, and reduces craving by the reward system, works on the reward system. And then we have phentermine, which is a stimulant from the family of amphetamine. It may be also have the topiramate added to it. Topiramate is an anti-seizure medication. The mechanism completely is not understood, but it looks like they affect the hypothalamus to decrease the appetite as well. We have 2 other medications that they work in the gut. Cellulose citric acid hydrogel is debatable if it is a medication or the device, because the capsule that has cellulose with the good amount of water can actually expand in the stomach, and kind of gives us the feeling of fullness. To be honest, I haven't prescribed it at all. Either was not available, or insurance is not covering, or the patient didn't like the idea. So, but it is something that works in the gut. Orlistat is a medication that is FDA approved, but it's over the counter. It pretty much blocks the digestion and absorption of the fat from the intestine. About 30% of the meal fat does not get absorbed. So the problem with that is when we have that fat malabsorption, the side effects might be a little annoying. So with the fat malabsorption, they may get diarrhea, they may get bloating, abdominal pain. So usually the side effects is prohibitive. But it is a good medication because it also affects the blood sugar control and the lipid profile as well. So if it is possible, that certainly can be a good medication. But as I said, it is difficult for some patients to tolerate it, plus the fact that it's over the counter. So the cost is always an issue. So we have the newer generation of the medications. They are gut hormones. So GLP-1 with or without the GIP is a class. We have more in the pipeline with 2 hormones, 3 hormones. They're just kind of doing the studies on them. But the GLP-1, as we discussed in the energy control, affects the hypothalamus to decrease the satiety, stimulates the reward system, decreases the craving. It also decreases the motility of the stomach and intestine, especially with the stomach. It's going to be a early satiety because of the movement is decreased. So originally this medication started for the diabetes treatment. The 3 that are FDA approved for weight loss are liraglutide, semaglutide, and tirzepatide. They're all injectable for the weight loss, except for semaglutide that recently FDA approved the oral semaglutide as well. They can, aside from the appetite and craving, increases the glucose metabolism, increases insulin level sensitivity, and decreases the glucagon. It also has other effects on other organs aside from the weight loss. So has cardiovascular benefit in the progression of fatty liver or treatment of fatty liver, and also sleep apnea. These are all FDA approved for those treatments as well. And the third modality is when we have more than the amount of weight loss that is expected from the pharmacotherapy, bariatric surgery. So bariatric surgery procedures, I didn't add the endoscopic, but we have endoscopic and the, just the laparoscopic procedures. Laparoscopic procedures, sleeve and gastric bypass are the most common one that are done. They have been around for a long time, and they are really, they have been perfected. So very little percentage of the mortality. They are low-risk procedures, and very similar, perhaps, like an elective gallbladder surgery. And the mechanism of the weight loss is not just the stomach is, and I hear that from my patient as well, that they don't want to go for surgery because if they could control what they are eating, they didn't need the surgery, or they didn't have to go there. So they have to control their eating first. Or I hear that, well, they're going to cut my stomach. I just cut back on what I'm eating. So, but that the mechanism of the surgery, again, is very different. It is not just the stomach that is small, but also it affects the hormones, the gut hormones. So of course, we're going to have restriction of oral intake, but also it changes the gut motility and absorption. It changes the gut microbiome, which is a very important factor in weight gain to begin with, makes the gut microbiome healthier, and also changes the bile acid composition that, again, affects the weight gain as well. So the outcome of the bariatric surgery also, they have been around long enough that they have long-term, data on them. So the amount of weight loss that is expected is 20 to 30% of the total body weight loss, about 60 to 70% of the excess amount of, weight loss. And it is sustained more than 25% weight loss over 20 years. It is significant. Surgically treated patient, they have a greater likelihood of remission in diabetes, high blood pressure, and lipid profile, and other complications, but these three specifically significant likelihood of remission compared to the patients that were medically treated. Surgical treated patients also have lesser likelihood of new onset diabetes, hypertension, and dyslipidemia compared to the medically treated. MI and cancer mortalities have reduction of 24%. Over 20 years. All-cause mortalities are decreased 30 to 50% between 7 to 15 years compared to the non-surgical patients. So it is a very effective treatment, but of course it's surgery, and like anything else, any of the treatments that we talked about, obviously is going to be affected by insurance coverages, availability, and all those things. But these are in terms of the benefits that they have or how they are causing weight loss. I think I talked too much. So if anybody has a question, we're going to talk about the question.
Oh, thank you. So I think you mentioned in that one of the graphics where it showed all the things that interact with the genes and then lead to the different phenotypes, as you said. But what about, I guess, I've read about I think it's called adverse childhood exposures, I don't know, or events, I'm not sure. So trauma, things like that may have some kind of psychological or mental impact. In your readings, had you come across, how does that play into the development of obesity? What is going on in someone's mind or what they're exposed to?
Yeah, I'm certainly not expert in the neuroscience or the psychology, but that certainly, is under the social, social and psychological factors. So all of these things can affect it. Might be the behavioral, might be, the fact that those traumas can actually make the person more towards a maladaptive eating behavior, causing depression and anxiety that by itself can affect their eating habit and the, the energy use, and also the, in the long term.
Mm.
One thing is about, I'm not sure about, if you're kind of talking about the trauma, just the childhood, but even intrauterine, during the pregnancy, the things that mother does, the healthy environment the mother does affects the, the risk of obesity for that child growing up. So, for example, if the mother has weight problem during the pregnancy, that child is going to have a higher risk of, obesity growing up. But if the mother loses weight prior to the pregnancy and start really kind of in terms of the diet, and have a healthier period of the pregnancy, the risk of the pregnancy, risk of the, the weight or obesity decreases. So again, mechanism of exactly the trauma, I think it's going to go under the category of social, social and the psychological factors.
Thank you.
Going to be the influence of the new rules and regulation by the Medicare in regards to the pharmacotherapy, especially GLP-1, and do you already feel that kind of difference in your practice with your patient?
Yeah, I mean, the patients already, as I said, they have a difficult time even coming forward to ask for, a treatment. And when they, get into that really kind of back and forth between, the medications, the expense and all, a lot of them actually, they stop trying at all. So it is one of the factors that is, really kind of preventing us from appropriate management of the patient. So those coverage also, from my point of view, again, we are just keep emphasizing this is a chronic disease and this patient needs to be treated chronically. But then, after they're starting it, they're losing weight, the insurance coverage changes, they have to stop it, they have to change it. It's a lot of, obstacle on the way. So certainly it's not helping, that's for sure. Yeah. But of course, I have to say that, we have had a lot of perhaps inappropriate use as well. So we have to kind of, look at that. So I mean, not much for, prescriptions and what, is, from the, the obesity programs, but, online places and, they get a lot of, medication just for, again, not necessarily for indicated uses, maybe cosmetically and things like that. Of course, they're not, taking care of that type of weight loss, but I feel like sometimes the resources are a little kind of, differently allocated, but no, I'm certain, I don't know if I answered your question, but it is a very, very good question. And I'm not sure what the solution to that is going to be in terms of the healthcare. Are you prescribing that in your practice?
Yeah, I'm prescribing.
So how have you, what is
in the practice, I'm more in the hospital, so I don't have that many patients as your clinic, so I still haven't felt that pushback, but it's inevitably gonna come with the new restrictions, and then we'll see. Probably it's gonna be, for the patient who's have enough money, they're gonna keep buying the medication if they're working for them.
Can't pay attention that it's a chronic use. So it needs to be a chronic treatment. So it is going to be an issue. Very effective medications, absolutely. I mean, we want them around, but what is the answer? I have no idea. Otherwise, I could have done something about the healthcare altogether, right?
Do you have any questions online?
Very good. Okay.
Okay. So this new food pyramid, I which the foods that are on there, for the most part, looks like foods that were on the old one, and although it seems a little more complicated trying to figure out how much of whatever you're supposed to have, but in the population that you're working with and talking about diet, and I know you mentioned the Mediterranean diet, and so probably that may still be your answer, but how do you think these new recommendations might affect working with patients, or if at all?
First of all, I have not seen that. I didn't even look at the new pyramid, so maybe I should do that. But I think any changes in guidelines, brings more questions regardless, and we have to really kind of see how we can address those. But in terms of the diet, the pyramid, as I said, I am really advocate of the Mediterranean diet. So regardless of what the pyramid is and where it is, we have to really kind of cut back on processed foods, for example, the ultra processed foods. We have to make sure that we are getting the what do you call it, the protein that the patient, for example, needs, but a healthier type of protein. So the way I look at the Mediterranean diet is the natural food category, nothing processed or things like that. But also within that, like if it is a protein, is a carbohydrate, is a fat or lipid, it's going to be healthier option. So the fact that we are not really telling them to cut back on the, let's say, something very little, amount, and they are allowed to have the variety, makes it more sustainable as well. But in terms of the food pyramid, I'm sorry, I don't even know how it changed. Do you have any answer for it?
I have looked through the new food pyramid, and these are coming out from the Heart Association. Yeah, it does preface whole foods, less processed, which is great, and it hasn't, done that before. They're finally addressing that. But as far as from a healthy fat standpoint, they do have pictures on there of, more beef and the full fat dairy and things like that. Which the Heart Association is still saying, yeah, we want less of the saturated fat. So yes, we want whole foods, we want, that, but we want less of the saturated fat. The pyramid right now is kind of inverted. It still has kind of all the components, but there is still a lot to go through with that. All the different associations from the, from even the, the medical and from the, dietetic standpoint. And like I said, the Heart Association, they're still coming out with their take on it. But again, those are for the guidelines for Americans. So we have to take that into consideration. They're kind of general. So, someone that has maybe heart disease or the genetics or, 4 different things, or even, like diabetes or obesity and stuff, your needs are going to be different. So they're going to be different from those general ones. And that's why you would go to, a nutrition services or something like that to get that specifically for you. And even in the preventative stage, that's what it's about, finding out ahead of time so that we can maybe prevent some of these, But yeah, they're guidelines, but again, they're just that. They're general.
I was going to say, I mean, those discussions usually are with our dietitian, mostly. So I don't even think the old pyramid really necessarily anybody was asking question, at least from me, but it is very important when they're going to really kind of into the details of their diet. And I think we're going to get more questions about that perhaps going forward. But
questions on the validity of some of the things that we've been telling people are going from. And, it's just basically everybody is individualized. Not everybody's the same. And that's the thing is what protein status is for Dr. might not be the same for me or for you. The fat status as well, and again, it does come back to that Mediterranean diet. That's a wonderful, those healthier fats. So again, it's not really a big change. It's just they're more emphasized and less processed, which in the grand scheme, we do it anyways in our end.
But I just want to also mention that how nutrition is getting even more important with those GLP-1s. So this is something that we really kind of have to emphasize again, just to make sure that the patient understands, you know, that not only the weight loss, you know, that they need to have the, again, calorie deficit or those macronutrients and all, but how important it is to make sure they're not going to have deficiencies, they're not going to have muscle loss. And these are things that is going to be all, you know, kind of, you know, on protein and the food composition. So
We do run into that.
Yeah.
where People think, okay, they have the surgery or they have the GLP-1s or something.
Yeah.
And that's it. Like, oh, okay, this is gonna work. But we have to tell everybody, you need their lifestyle changes too, in order to be long-term and to see the full benefit.
We do have a question online. When patients on GLPs reach their target weight, do you recommend continuing them, stopping them?
the short
Or
yeah, go ahead.
does
Go
it
ahead.
depend on the individual patient?
So again, it's back to obesity is a chronic disease. We need to continue. But when they get to the goal, so for example, you know, again, we really don't have necessarily a universal guideline about it. But when we get to the body mass index of 27, for example, that is the indication to start the medication to begin with. We start really, you know, look at, you know, how the patient is doing in terms of nutritionally, diet and all, but also, you know, start to really, at least that is what I do in my practice as well. So I start to taper the patient off to the minimum dose that they maintain their weight loss. So we're not going to go full ahead, just, you know, continue with the weight loss or just the highest dose that the patient is on. But the answer is that we have to, you know, continue the medication to be able to maintain the weight loss.
Thank you. And one more.
Yeah.
Curious what your thoughts are on patients getting commercially available GLP-1s on their own when they could benefit from weight loss medication but don't qualify through their insurance.
That's a very difficult question again to answer. Because first of all, I myself do not recommend necessarily going from online, and because they're not FDA approved, and a lot of questions may kind of rise about that. But if they do not have indication, I mean, I'm not sure, they don't have coverage or they don't have indication.
I guess it says just they don't qualify through insurance. So whether they
Through
don't
insurance.
have insurance coverage or maybe the insurance isn't going to
It's a very
cover
good
it.
question and the problem that we have. So in that situation, we go back to other alternatives, other medications maybe. So if we have to individualize and see what you know, how that goes, but look at alternatives for now, at least until kind of we figure out.
All right. There's no other questions online. Anything else in the room before we wrap?
Well,
Okay.
thanks. Thanks.
Thank you. That's good.